I'd like to launch us into session 4 with the Leadership, Governance, and Partnership session. And the moderator for this session is Dr. Alastair Robb from the WHO.
So, thank you very much. At a meeting earlier this month, I had to sit through 40 PowerPoint presentations in one day. 40 PowerPoint presentations. The audience was numb. So we decided we're going to change that, and we're not going to have more PowerPoint presentations, and we're going to follow a UK TV presentation mode, a program called Question Time. Has anybody heard of Question Time? So what happens in Question Time is you get a panel of experts onto the stage, and questions are posed from the audience. So that's what we're going to do now. So you've got to now imagine yourself as an audience in BBC TV, very British, and a number of you will be posing questions, and I have a panel of experts who will come up to the stage now, please. So let's hit it. Good afternoon and welcome to Question Time. My name is Alastair Robb, and I am joined by a high-level panel ready to answer questions from the floor. As soon as I get my act together. So I have a group of people, and I'd like to introduce them. I have Dr. Dedi Kuswenda. For an audience question, what was the next theme tune? Does anybody know the answer to that? Ski Sunday. Anyway, totally irrelevant. So I'd like to start again. I'd like to introduce Dr. Dedi Kuswenda, the Director of Health Promotion and Community Empowerment, and the Director General of Public Health in Indonesia. A round of applause, please. I'm also joined by Mosidi Nhlapo, and I'm sure I pronounced that incorrectly, the Chief Survey Statistician from Statistics South Africa. Debra Jackson, the Senior Health Specialist of UNICEF, Professor at University of Western Cape, South Africa. And Dr. Ishtiaq, Save the Children Director of Health, and 20 years of experience of system strengthening in Bangladesh. So I'm going to ask for the first question, which has been posed by But Sabine from Cambodia. And can we have a microphone around to the audience?
Thank you. On behalf of the Moderator team, I want to ask you, how does your country use data to achieve equitable health benefit? And what more should be done to improve the analysis and use of data for this purpose?
Thank you very much. Can we put that one over to you, Director of Health Promotion and Community Empowerment? Because I think it really is about how you at government level strengthen the use of data to achieve equitable health benefits.
Okay, thank you for your question. First of all, thank you very much for here to talk about how can analyze the data for the. In our country we have a lot of health center in the sub-district where 9,700 more, and then we have also a lot of the island of Indonesia is about 17,000, and then the people is about 250 million, and that's why we use that health center for the data. We have the program in Indonesia is about the family, how to the families okay in the field. The health center came to that house, and then they are looking at the problem of that family and then put the data in the health center. And then after that, they use for the planning how to implement, then how to make the families okay, like LCD, like the DG from Bangladesh said. We use like that. That we also have found for to take the problem of the family. They have the analysis from the health center, and then after that go to the sub-district, and then the district, and then to the center. We have a lot of data, and then we can take the problem of the health center.
Okay, thank you. Ishtiaq, would you also like to give a perspective from Bangladesh?
Sure, thank you. But before I start, I just wanted to mention a note of caution, because I was in the lunchtime when I met Professor Azad after his stunning speech. So I think it's very difficult to, or it's maybe not necessary to say anything after he has spoken about Bangladesh information system. So having recognized his overarching, overwhelming, comprehensive presentation. So, and I'll be very careful after that. So, interestingly, Bangladesh seems to be a very small in terms of geography country, and with a huge amount of population here. And it's very easy to think that it's a homogeneous country. It looks like homogeneous, but it's not. And when you look at the data, you see that there are huge disparities in terms of geography, in terms of socioeconomic status, in terms of gender, and in terms of other demographic profiles. So as the question was in terms of how do you really use that data to address the inequity issue, and in the upcoming years, the next 15 years, actually what we will be dealing with not the averages, not the national averages, but the inequities, desegregation. Fortunately, Bangladesh has a good, at least survey data availability that provides various levels of desegregation. If I name Bangladesh Demographic and Health Survey every 4 years, regularly happening. Bangladesh Maternal Mortality Survey we had every 10 years, now we are going to have one again in 6 years' time. Mixed data provides us. Even Bangladesh Health Facility Survey, the preparedness data, we are going to have it regularly. We just had one in 2015. And all these national surveys, which are robust, quite comprehensive, provides a lot of desegregation by geography and other means. And interestingly, most of the planning processes at the national level take into cognizance this desegregation. I won't say that we have made the best utilization of the desegregated data that we have. Still, we are talking about this differential planning, differential investment, so that at one hand we have very good data availability, and these are desegregated up to some extent that can help the planners very well. So this is one side of it. On the challenge side of it is that I would say that we haven't made the best utilization, because it's not because of the data that we have, it's because of the limitations of the planning processes that we carry from the British legacy. The entire bureaucracy, and it's nothing to do with Ministry of Health only, it's a national issue, I would say. The planning processes are universal, there are political pressures. So I think when we talk about use of data in ensuring or addressing inequity, we have to think of the both sides. Have to have the data, but then even if you have the data, you have other mechanisms to make sure that you are able to use that data in differential planning. There's a small point on how you're going to improve that data, what can be done. I think what needs to be done now in the next, if we are going to achieve universal health coverage, you really need desegregated data. And it's, whenever you talk about desegregated data, you need investment. Just think about the poor district managers. The very fantastic DHIS2 system that Professor Azad has talked about is a robust system. But if you want the district health manager to use that data in terms of planning or finding out the low-performing pockets, even at the ministry level, you need that data to be desegregated by different parameters. So that desegregation, and also for the national surveys, Now, say for BDHS, demographic health survey, you have at a divisional level desegregation. You want district level, even at sub-district level, because, as I have said in the beginning, this is not homogeneous. There are pockets, just next door, you have the low performing pockets. The other thing that I want to end my talk with that is that you need the capacity to read data. There are, even I think, the amount of data, and all of us will definitely recognize, there is another disjunct. The amount of data that we have, the capacity is not that. So you need to have that capacity at every level, I don't think that at the ministry or at the national level only. At the local level, you need that capacity to read that data and act on it. Thank you very much.
So, thank you very much. It's great to hear the criticism of the British colonial system on BBC TV. Very brave. This question was about equitable health benefits. So I'm just going to ask Debra if she wants to make a comment from the UNICEF perspective.
Okay, thanks. I think this, it's speaking about use of data, and one thing that, speaking a little more globally, is that UNICEF has a product which has been developed called Equist. And when we talk this session's about partnerships, that was in partnership with the World Bank, Johns Hopkins University, UNICEF, now University of Pilates. And basically it's software that takes the data that, that our colleague was speaking about, whatever's best locally available data. It combines the World Bank, NBB, the list, and also Tanahashi bottlenecks. And basically can, down to a granular level, at district level, put in the data, look at various interventions, and try to determine and help local decision makers budget for these groups, especially the inequitable groups. So because it comes down to a low level, and because it can then look at different population groups using a list and that sort of thing. So I think that there are more and more options for assisting local governance as well as national governance to use sort of modeling and a lot of the tools that many of our academic colleagues have developed for decision making. And Equist is just one of those. And I'm sure there's many others.
Great, thank you very much. Thank you very much. I'm now going to go to another question from the audience, from Farida Sibwe of Indonesia. I apologize if I mispronounced that. Could we have a microphone to Farida?
Thank you. My name is Farida. I'm from Indonesia. My question is, what is needed to strengthen the overall statistical capacity and system in your country or community?
Mosidi, I think that one's right up your street, so over to you.
Thank you very much. I think two key things, I think in the case of South Africa that we've done, that we had, or maybe I should say, is the political leadership and the political will to change things and for progress. We've seen that in the area of CRVS, the strength that we've made in South Africa in CRVS development and improving the CRVS systems over the last couple of years has been actually recommended. Also, the statistical leadership. I think for Statistics South Africa, it was in our best interest to take the leadership for anything related to data and data improvements and data quality improvements and to strengthen the statistical capacity in the country. One of the things that we've done is to support and to take ownership of the national statistical system. And there are various things that we've done through that. We have, because we are moving as a country to try and see what is it that we can get from admin data, including the CRPS. And admin data that sits in government, will it be education, health. We have implemented what we call SASCAF. It's a quality assessment framework where all the stakeholders that produce data for admin purposes if they want the data to be used for any kind of analysis or for evaluation, we subject them to that framework. And we've had a number of partnerships across the country with private and with even public entities, where we go in, we have a memorandum of understanding between us, and we will actually go into their system and assess the data and see if the data can be used to estimate anything or for indicators. It has worked in some institutions, in others it's still a work in progress. On the issue of the CRPS, we have actually, as I say, taken the leadership, and we have a working group that we are currently doing the assessment. But as you know, South Africa's CRPS is actually very old, but in the post-apartheid period, the government has shown the political will to improve. And our coverage, we've seen coverage improve tremendously for deaths. There's still challenges, but just the willingness across for the partners. We partner with health, we partner with the Department of Home Affairs, who do the registration. We are on the administrative side. One thing that we still need to work on is for the roles and the responsibilities to be documented, and for everybody to understand that it's a system. I'll make an example. If for status ABO, because we are at the end of the chain, we are the one who have to sit with the data at the end of the day, and the quality issues come to us. So we've had to take initiative to intervene, to suggest changes, and I think because of the partnerships that we've had with our other stakeholders in the system, the Department of Health, the Department of Home Affairs, who did the registration, we've actually been able to say to them, can we go and change this and change that? We've changed the notification form to try and capture some of the indicators that are important for reporting. And I think luckily we've actually, in the last couple of years, reported based on the register data for the MDGs. I think for three consecutive MDGs reports, we use the Vital Register. It still needs to be, there still need to be adjustment for completeness, but at least we understand so many things about our population from the Vital Registration System. And I think thanks to that, it's mostly the leadership that is required, and the understanding that it fits back into understanding our population as a country. And it allows us to also attend to challenges as they come, because we've come to a broader understanding as a country about such issues.
Great, thank you very much. I think that's a really interesting perspective of the broader system in which this takes place. Do any other panelists want to make a comment on this question? Yeah.
Quick comment. It's like, what do we need for statistical capacity? And one of the first things that came to mind is we need people who can actually do maths. And so this is another partnership with your education, is to build your basic maths education. Because if your children can't do math and they're not literate in math, and they don't have math literacy, then you can't train them to be statisticians. So it's another partnership outside of health and vital statistics and CRPS that we also need to reach out to our education colleagues to make sure they're producing the kinds of people that we need.
Thank you very much. As a reminder, and it reflect on the questions asked this morning about the importance of capacity, and we're not just looking at the sort of end stage of capacity, we're looking at capacity to even do the basics, so that's really important. Can I ask the next question, which is going to be provided by Tulili Zondi from South Africa. Again, I apologise for every pronunciation of names, which I'm going to blame Mark for his bad handwriting rather than mine.
Thank you very much. The question I have is, how do you make sure that all decision makers, the mothers, healthcare providers, district planners, and national policy makers are armed with the relevant information to appropriately make decisions about their own health and the healthcare of their community?
Thank you very much. A very public health relevant question. How do you make sure that everybody, not just the policy makers, but everybody is armed with information to make good public health decisions? That one's for you, Debra.
Yeah, I mean, UNICEF, we tend to work at the community level. We work a lot with community engagement. We heard about community health workers earlier today, demand creation. One thing is community engagement, social accountability. What does that mean? And I think you've heard several, even just today from Bangladesh, from South Africa, of examples of how you can start to engage communities, both by mHealth or SMS or electronics, but I think that you also have to go beyond that. So you actually have to take the data that you're getting and you have to engage with the communities and let them see the data. You need transparency and you need to engage civil society, the health leadership, the your partners, and as well as the families and the community leaders to understand, to see the data and to have dialogues around the data in their community. And there's important things about this. One, it makes the local health services or CRVS systems held to account for the services they're providing. But I think also it increases the dialogue. We know that particularly in health, that what's one of the biggest contributors is social determinants of health, often things outside the health system. And where are those going to be addressed? Those are going to be addressed in your communities. So then you can build that partnership to have the community see where their role is and their responsibility for their own health and make it a two-way street. We've got several projects going on related to social accountability. A lot of donors are very interested in this area. So it's definitely something that you should be working on. Every woman, every child, every newborn action plan, they've all got social accountability components to their work.
Thank you very much. Dr. Ishtiaq, you've got 20 years of experience of health system strengthening. What does that 20 years show you in terms of making sure information is available to all people?
Yeah, 2 points here. One is that if you want to make sure that everyone is armed with data and they're really using that for this decision making, I think the first thing is that demystify data. Data should not be captive in a group of people's hand, pocket, computer or something. So it's a kind of make the data a culture, not a cult. So make it a culture. Talk about it, ask for it, discuss about it, make stories out of it. So that's the first thing. So we talk about digital divide. The data divide is more difficult to cross in terms of or overcome compared to digital divide. So we are talking about a lot of technological innovations and everything. But I think the basics are talk about data. As my previous speaker have said, that really you have to start at the root. Start with elementary education, where you bring in maths as part of everything. Even if you're going to teach literature, bring in maths perspective, analytical perspective into that, so that the data divide is eliminated from the very beginning. So that is very important. I mean, in Bangladesh, one of the challenges that we are facing in the early stages of our rollout of national scale MIS is that you go to a district hospital or a Mosidi hospital at the beginning. When we talk to the sub-district manager, do you know what is the kind of skilled birth attendance rate in there? He smartly either picks up the phone or take you to the another room where the statistician is sitting. So he says that, I don't know, but the statistician knows. So that still remains up to some extent, and that is a kind of a phenomena or symptom where data is not part of our everyday breathing. We do not dream data, we don't talk data. So that's most important. So make it easier, make it like storytelling. Data doesn't need statistical knowledge. Data is everyday business. So that's first. The second thing is that I would like to add that if you think about in last 1 week or 1 month, the types of data you have dealt with, mostly the public health professionals, particularly the managers who run the programs, we deal with a lot of outcome data, output data. But what we consciously or unconsciously shun is the system data. How many doctors were really present on the site? How many treatment given were at actual quality? So those type of difficult part of the data, we really don't like to deal with. So consciously or unconsciously we avoid. And also the systems we develop do not always necessarily bring in that system data. So, but our everyday decision making, when you are going to take a decision, make a decision as a policy maker, as an implementer, you need those system data mostly. You need them handy, and those are not available. Surveys do not provide that system data. So that's most important. If you want really people, drag people into use of data in decision making, day-to-day life, because decision making is every day's business, every moment's business. Every moment you are making decision. So back in your mind, data is working. If I ask you, how are you? You're going to say, I'm fine. But when you say I'm fine, actually back in your mind, you're analyzing several data. I'm not having a temperature now. I ate well. I did not have a stomach upset. Within a second, your brain analyzes those data and come up with an answer, you are fine. So I think that should be the way of looking at data use, not as a group of sophisticated white-collar statisticians dealing with data only.
So thank you for that. I think that's a very relevant point, and not all statisticians are white collar experts. Some of them are actually on the panel and are very informative. But you make a couple of really important points. That's not the way the show goes, by the way. We've all got it scripted. So we'll come to you in a minute, Professor. But you make a couple of really important points, and the first is about sort of the most important thing about relevance of data. That it's not just about telling people you need to use it; it's about actually seeing the relevance to your day-to-day life. And there is and this is a quick plug for the Health Data Collaborative. There's a working group on quality of care in the Health Data Collaborative because it seems a really important part of improvement that's needed in terms of overall healthcare. Before going to Professor, which we will come to, I just want to ask Dr. Dedi, from your perspective, where you've got such a massive population, that sort of ability to engage them in use of information, demystifying it, how far have you got in that process?
Okay, thank you. The process is, that what I said before, that we have the health center there, and then the data is came from the health center, and then we use the data first for the health center. Before said, we can use how to make that all the people there in the health center they know, because they have also the planning for that included health center. We have the data for the family, all the family, how is the NCD program, NCD, and then everything. Also the household, what happened in the household. And then they use that data. And then after that, we have the program to make that data go to the district and then to the center level. This is the program we have.
Okay, thank you. Professor.
Thank you for allowing me to give a comment. Actually, I am personally interested about this comment. How will give control of the health data, personal health data. Okay. I am interested to make a comment about how. I don't know whether
the BBC, I'm afraid, it's cheap.
I personally believe and recommend that we should educate the people in a way that the citizens, they take control of their own health condition and they take control of their own health care. And I believe that this is possible. This is possible. First of all, if we consider the situation in Bangladesh, I think 1 decade back, or maybe more back, the immunization rate in Bangladesh was not that high. In 1985, the immunization rate was only 22% among the unflight children, or eligible children. And now, in some cases, it is near 100%. So how it happens? In fact, the health workers, the healthcare providers are bound to immunize the children. If the immunization camp is not held, if there is not availability of immunizations or EPI logistics in the center, the people claim the big event. So, you know, the healthcare workers or healthcare providers, they have no other way than to keep the centers open or than to immunize the children. So this is the demand created by the people. So if we can educate the people in a way so that they take control of their own health, and then they will demand. And in Bangladesh, you know, the use of the mobile phone is near, I think it's over 95%. Every household there is a mobile phone. So people, they started with the analog phone. This is most difficult compared to the smartphone. And the use of a smartphone is increasing in the country. So the lay people, the illiterate people, one day they will understand how to use the smartphone. So if we can make the software in a way that they understand very easily, it has some pictures and other things, which will actually demonstrate them, actually their health conditions, and they will be interested in doing this. This will not happen immediately, but in 5 years' time, in 10 years' time, that will really happen. And on health data collaborative and actually the achievement of the universal health coverage, achievement of health-related disease, we have to focus on that so that we can actually enable people in a way so that they take control of their personal health. And if this can be achieved, the health will be achieved. Thank you.
Thank you very much. That's quite interesting because it looks like you've read the next two questions. So I'm going to now ask Wilma Gulen of the Philippines for the next question, please. You've got the microphone.
How have you created the space and capacity of local people in monitoring the performance at facility, subnational and national level? If so, how has it been effective? If not, how would you approach this in your country or from your perspective? What guidance is needed to effectively engage people? Thank you.
Dr. Ishtiaq, I think that's a good one for you.
So, yeah, we have really very substantive experience in community engagement, not only in improving the priority health agenda, but also managing data. So recently, but by recently I mean maybe 6 to 7 years, there had been or even more than that, there had been a paradigm shift in the health systems thinking in Bangladesh. Previously, it was kind of mostly supply-side driven clinical approach. That was the mindset. But the government, the policymakers, has shifted the policy with a very fundamental element being incorporated into the system, that is the community engagement. And that has been reflected by what you have heard in the morning, that we now have 13,500 community clinics. Every community clinic is covering up to 6,000 population. But that's not the paradigm shift. The paradigm shift is there have been a recognition of role of community, active role of community in health systems. These community clinics are a unique establishment. The land for these community clinics are donated by the community to the government. And then government, as it gets that voluntary donation, that's the first time community is thinking, I'm going to build my clinic, not their clinic, that means the government's clinic. Then government invested that there, built the clinic, put a staff there. Then again, these clinics are managed by community groups, totally community representatives, no government official out there, and be supported by 3 community support groups, which have a wider membership from the community, different groups of the community. So having that very interesting and unique interface at the very primary level of health systems, where the data is being generated, is giving ownership of that data. So all those community clinics have a community healthcare provider who is actually on a real-time basis entering data, the service data, into the DHIS2 system. So just imagine 13,500 community healthcare providers every day, every moment entering real-time data, and that system is being managed and overseen by a community group. So that's the first thing where you really see communities getting hands-on on data generation. And at the same time, in the management of that data process and the community cleaning process, there is a huge engagement of the local government, who are the elected representative, who are the people's representative, they're voice of the people, and they are members of that community group who are managing that. I won't say that we have reached to an ideal situation where really community is getting into the deeper depth of that data management, but at least at the generation they are seeing data being generated, they're seeing their own data being entered into the system and being used for decision-making process. So in terms of that community engagement, this model is really giving us a way where you can increase and really enhance the engagement of community in data generation, management, and its use. So community is part of that loop. You generate data, you put it in the system, you bring it back for your own development. So it's not a cycle, it's a kind of spiral where a stage is creating the next stage, which is a developed one.
Thank you very much. Debra, would you like to make a UNICEF comment?
A similar program, slightly different, is one. It's called MTRAK in Uganda. They've got a massive number of things that they do with it. It's been supported by many partners, WHO, I think USAID, UNICEF, and one of the pieces I like about that when we talk about engaging communities is the MTRAK is so that the local health providers can let stock out supplies. There's some electronic pieces for CRBS, but the piece I liked the best is that not only the health workers can report that there's a stock out, but the patients can as well. If they go and they needed something and it wasn't there, they can actually SMS to the number that they went for their immunization or they went for their vitamin A and it wasn't in. If they go and it's closed and the health worker's not there, they can report, health worker didn't pitch today. And so I think that kind of community engagement to report on problems, as well as positive things. But I think that those very specific things where they can actually know if supplies are there, if the clinic's open, if the person was there, and for a provider to know that if I don't pitch, somebody may report on me, and not just that my supervisor is going to come in 6 weeks' time, and that also the supplies that because we know that people go, if they don't get service, they don't come back. And so this makes them then can be responsible. So I just thought that was a really interesting one from an example from Uganda.
And for those interested in looking at more about MTRAK, it's MTRAC. If you look it up on the internet, and it is fascinating because it is about engaging communities. It's using a mobile phone in some cases for real-time anonymous feedback free of charge. So the mobile phone companies have done it free. It's anonymous, which is a really important part of the system so that people don't feel they'll be prejudiced against their next encounter with the system. And all of the system is informed so that all different duties of improving the system are made to work. So look it up, it's really fascinating. Okay, next question is from Dr. Thakur of Nepal.
Again, my concern is regarding how this system is working, and so many countries are waiting to implement all these new ideas. So my question is, at the peripheral level, how the people are getting the benefited, how we should have to sustain the program, and partners will not be involved, then how country alone they can sustain it. So these are my concerns from my country.
So I think that's an important question about how we can sustain some of this work into the future. I'll start with Ishtiaq again.
two elements in your question. One is that definitely how do you sustain that? And I think you have given the answer that we need partners to do that. So simple as that. So when you have partners, you have, and as I have just given you an example from Bangladesh, and I think we have heard from MTRAC as well. So partnership is key. You need to really own that data. Own the data. Data are not number. Data is life, and data is a number that talks of your life. So once your data talks of the life of people, that is owned. That is owned by people. That is owned by the system. So that's key. So you need to really I think the systems that are being developed in a top-down method, that's difficult to survive. That's difficult to be owned by the users. So countries which are at the very elementary level should not make that mistake. Involve partners, involve the owners, and involve the community to sustain that system. And that it's easier to say INVOLVE, involve, but that's the difficult part of it, how you really involve people. Because involvement at different level takes different level of efforts of involvement. Just think about a woman in a remote rural area who has never come out of her village and being pregnant there, then in the middle of the night bleeding and bleeding to death. Now what is her involvement in data? So you have to be really innovative. She and her family needs to have some kind of data that where is the nearest health facility, when it is open, where is the provider staying, what is the phone number of that provider which she can call. So those are also data and information that need to be available to that mother. For that mother, maternal mortality of 194 per 100,000 live birth doesn't make any sense. So you have to really devise appropriate data for different level, and you have to really disseminate that, involve those people into those generation, and only that can be sustained in the longer run. The last point that I would like to say in terms of sustainability, look at the SDG 17 goals. I mean, data robustness has come up very quite comprehensively this time, which was not the case in MDG. I think that is one of the lessons that we have learned in MDG, that without data, everything is opinion. So where you have data, that is evidence. Other than that, everything is just an opinion. And you cannot really live your life with opinions only. So you need data, and that data needs investment. So I think I would urge to the governments and all the other partners here that if we are living in a world of thinking that with minimal investment we can reach universal health coverage, that will remain a dream. We need to invest, and most of this investment need to go to data generation and processing.
Thank you for your opinion. Now I'm going to ask Quadron Nahar from Bangladesh. Maybe I pronounced it incorrectly.
Sorry, I have raised my hand again to ask question. So as my question has not come up from the participant completely, as I am a MMA person, my concern is about the data and about the confidentiality. So my question is, how you are ensuring confidentiality or privacy of in collecting data, management and use, and what measures you have taken or what measures you will take for ensuring confidentiality. And according to you, what leadership or guidance is most useful in creating an ethical environment for data collection and data management and use?
Thank you very much. Mosidi, I think that's a good question for you because you're looking across the whole landscape of data, and it must be an importance to every bit of your work.
Okay, thank you very much. I think that particularly in the area I work with, data confidentiality and the privacy has become such a contentious issues in South Africa, especially the CRBS data that my division works with. As the data improves, there's been increasing demand for access, and some of it has been even for unit record data and anonymized and identifiable data. And one thing that we are not prepared for as South Africa is to get to a point where we deal with such issues. Because we were just so concentrating on improving the quality of data and improving the completeness, such that now we found that the fragmentation across legislation that deals with that issue. You go to health, there are certain things that the Act in Health Department can allow in terms of access to data. The Statistics Act is particularly very strict around confidentiality. And it sort of creates loopholes because the data belongs to a number of stakeholders. One thing that countries need to do is to look at the legislative framework, and I think the earlier it's done, the better for the country, because then it protects the data, it protects the people who give us information about themselves, about their loved one who died, about people who go through the health system. That once it's legislated, it gives each person that has to make decision about giving access to data the confidence to know that you have some legislative framework that protects you. To me, legislation is key.
Thank you very much. I'm conscious of time, so I'm going to just take two more questions. And the first question is from Dorji Pelzon of Bhutan.
Good afternoon, and thank you very much. My question is, how are partners helping you in the collection, management, and use of your data in your country or community? And the other question is, what is needed to ensure more effective alignment of donor and technical partners and disease programs with the national monitoring and evaluation plan in your country?
Thank you very much. A real question about alignment and managing donors and development partners. Dr. Dedi, could you give us some advice from your experience?
Okay, thank you. In my country also a lot of partners. We have the, in the central, we have the meeting for how is the data and the program of the partner before they use for the program go to the field. And then after that, we have agree about the how can we can take the data, how can we can take the program, and then we can, after the finish that program, the partner, and then we give to our budget, because we know the program of the partners, and then we can go along with the partners, and then we move to our budget to make that program is sustainable.
Okay, and then the final question from Arif Khan from Bangladesh WHO.
My question is, how can countries and communities balance local needs for data with a more global or regional focus on the SDGs, the donor priorities, and other partner priorities? Thank you.
Great, and a very challenging question, and therefore one that I'll pass over to UNICEF.
Actually, I did agree. It's both a hard and easy question. I think the thing about national data is aggregated from local data. And so if the local data is not good, and the national data that they're going to report to the SDGs won't be good. And so that you need to look at, and we've been talking a lot about local use of data, and we talk about outcomes. If the local communities, the districts that can see their data, they can use it to improve their own outcomes, then that's going to improve the outcomes at the national level and make the country look good for the SDGs. And so it really starts at that level. I think that the other thing regarding to donor priorities, obviously I think governments need to take more of a leadership role. They do, and they're really getting much better at telling us what they want and what they don't want, and that's great. And we do want that. But Also, in working with donors is, I think that if you've got better data as a country and as a locality and a region, that you can then more easily direct donors and partners to what you need. And even if they come with their own agenda, which they're still going to do, at least you can say, this community actually has that problem, or this is the community where we want you to go, because we can see from our data that that's where that needs to be, so that they're not coming in and going to all the usual subjects where they usually like to work because it's easy. So if nothing else, they come with their agenda, you can send them to where you want them as opposed to them doing their own thing. That's would be my ideas.
Do any other panel members want to make a comment?
Just to reiterate what had been said, I think definitely when you look at the slide which has all the graphics of 17 SDG goals, this slide really looks nice. It's very colorful, very daunting, very alluring and whatnot. But at the same time, I think for the developing countries and the countries who are really aspiring to come up over the barriers or some of the very basic barriers, I think there is a danger to it. And that danger is, I state it as a danger of translation. If we cannot really translate the goals, the indicators into our own context, and then the second issue is the prioritization, then we are going to be lost. So that has to be taken very seriously, because there will be all demands from the global communities. There will be a lot of demand from the donors' pressures. I think the governments of the countries like ours need to sustain that pressure. Really need the leadership. The entire question of leadership is to kind of sit tight and stay to your course and make sure that you give out the message. We need to maintain the course and the speed that we have gained. So a lot of destruction may be a challenging issue to handle with. So we need really very strong leadership and negotiation power on the data side as well. We cannot keep generating data that we cannot use. Data, every bit of data is a cost. So you have to make sure that we are cutting the coat according to the cloth.
I think that's a really important message for us all to take away. So the importance of leadership at national level, and the importance of not just stating that we're aligning with national governments, but the true alignment, both technical and financial alignment with the cause. And I'm going to just hand over to somebody who actually has to deal with this, not just from a health sector perspective, but from the wider perspective.
Okay, thank you very much. I think I wanted to talk to the alignment between local needs and regional reporting and international organizations. What we've done, let's just say, we went through an exercise where we aligned the major policies in the country. We have the National Development Plan in South Africa. We identified the indicators that are common across for the National Development Plan, which answers to South Africa's development challenges. And we looked at the SDGs, those that aligned with the SDGs, and they are similar across. And we also looked at, on the African continent, Agenda 2063, which is a continental requirement. And we went through the exercise to even go to the level of looking at MTF level, at a much lower level, where it looks at performance. And we found that we could identify the indicators that once we estimate the indicators, we know that we've solved certain of our issues. And we can see indicators that are irrelevant for South Africa and those that we can actually just do and they can benefit us as well.
Great. Well, we're going to leave it there. I think we've run out of time. I'd like you to give a big round of applause in BBC's tradition to the panelists. I'd like to thank all those who raised great questions, and we'll be meeting again at BBC next week for the next round of question time. Thank you.